that goes up her throat. It usually happens after eating a hearty meal and goes away on its own, except for dry cough during bedtime, which was usually relieved when she drinks warm water and adds another pillow for her head. Of her prompted ER consult, Kesia, weight loss. There was no difficulty of breathing, shortness of breath, easy fatigability, or orthopnea. She has no vices, no previous hospitalizations, and has a family medical history of hypertension from both parents. Her physical exam shows a blood pressure of 140/80, heart rate of 90, respiratory rate of 20, and a BMI of 33. Her other findings, including the head and neck, throat, nose, ears, chest, heart, abdomen, and extremities, are otherwise unremarkable. And this is her ECG taken from the ER as well.
I'd like to deliver first a mini lecture on the many phases of gastroesophageal reflux disease or GERD, the typical and atypical symptoms of GERD, and third is to elucidate on the various diagnostic modalities for GERD. Gastroesophageal reflux disease is a condition wherein the acidic stomach contents frequently flow back or reflux into the esophagus, causing symptoms and or complications. This happens when there is an imbalance between the defensive factors which protect the esophagus versus the aggressive factors. First is, on the other side, we have the aggressive factors, which include gastric acidity, the volume of the refluxate and the duodenal competenta, as well as phrenoesophageal ligaments, and the location of the lower esophageal sphincter at the intra-abdominal region. The food downward to the stomach, the volume of the food bolus per se, and the saliva acid neutralizing capacity. Now for the tissue resistance, this includes the pre-epitheal defense, wherein there's a secretion of what we call mucin and the prostaglandin E, which consist of the mucosa as well as the submucosa, which also offer defense against noxious stimuli, as well as the... Now on the aggressive factors, we have the increased gastric acidity, which is noxious to the esophageal epithelium, the volume, the refluxate, the presence of bile and of stomach contents into the esophagus. Now there's another concept which is acid packet. This is a localized area of gastric acidity at the proximal stomach that escapes the buffering capacity of the food after a meal, and this is said to be responsible for the postprandial acidic reflux. Now for those who do not respond to the gastroesophageal bile reflux, two is those patients with visceral hypersensitivity. Third are those patients with delayed gastric emptying time, and those with psychological factors like patients with worries who are with anxieties or problems. How about the symptomatology of GERD? Esophageal in origin versus the atypical symptoms, which are coming from the chest, the lungs, and the ear, nose, throat region. And the regurgitation is the refluxing back of the refluxate into the esophagus and even to the throat. These were found in our patient presented to us. Dysphagia, or the difficulty in swallowing, say that there could be patients with progressive dysphagia to solids. However, severe peristaltic dysfunction or even precancerous lesion like a Barrett's esophagus. Now, odynophagia is painful swallowing, and this is usually associated with esophageal ulcer. However, this is a common GERD symptom, and if this is so, we should correlate this with feeling of foam or hypersalivation in patients who respond to the reflux. This can be a symptom of GERD both in adults and babies. Nausea and vomiting as well are not that common in patients with GERD, but patients who may present this with persistent nausea vomiting should be investigated for other diseases like hepatobiliary diseases or even obstruction. Now, how about local data? In 2012, Dr. Mejia studied the prevalence and risk factors of erosive esophagitis among patients with GERD at Manila Doctors Hospital. He studied about 139 patients, and he found out that majority of these patients experience heartburn, 81.3%, followed by regurgitation at 71.2%. However, if we examine the total number of patients with these symptoms, this exceeds number of 139. So it's possible that the patient may present both with heartburn and regurgitation endoscopic findings, or what is known as NERD, 37.4%. However, in majority of cases, it was found out that 62.6% of these patients had lesions. The most common is esophagus, grade B at 10 point, and minority grade C at 3.6%, which pertains to those already with peptic stricture and even Barrett's esophagus. What are the atypical symptoms of GERD? These include chest pain, globus sensation, chronic cough, sleep disorders, and laryngopharyngeal symptoms or LPRs. Now, and this can be described as squeezing or burning type of sensation located at the substernum, which may radiate to the back, the neck, the jaw, and even the arms. This can last for a few minutes to hours and can be relieved spontaneously or with water intake or just antacid intake. This may occur with after meals and awaken patient during sleep. Also, some patients may have emotional stress as the trigger. Our ENT colleagues would refer to us patients with this kind of complaint for further investigation. However, when we do endoscopy, we cannot see anything or any abnormality in this group of patients. Now, furthermore, other ENT symptoms include chronic laryngopharyngitis, which cause hoarseness and even throat clearing in some of these patients, sinusitis, as well as vocal cord abnormalities like this nodule, as well as dental erosions. Pulmonary, like wheezing, recurrent bronchospasm, and recurrent aspiration pneumonia. How do we diagnose GERD? So first is clinical evaluation and endoscopy are very important means to diagnose GERD. Rarely do we resort to 24-hour pH monitoring, esophageal manometry, and impedance analysis. Now, with regard to the clinical evaluation, we cannot overemphasize again the importance of taking a very good history and physical examination. This can also be done through surveys, through GERD questionnaires like peer treatment or trial treatment with PPI. Initially, endoscopy may not be necessary, but after adequate treatment, after 4 to 8 weeks of PPI treatment for these GERD patients who do not improve, then we can suggest endoscopy. Now, for elderly patients with both typical or atypical symptoms, regardless of the severity or duration of the complaints, then we should suggest endoscopy. Through endoscopy, we can actually see and investigate the presence, the severity, and complications of GERD with mucosal breaks more than 5 millimeters. So this is classified as B. This one is already with peptic stricture with erosion, so this is classified as LAC. Now, this endoscopic picture is one with the hiatal hernia. You can see this in retroflex view, that you can see that the scope is snugly hugged by this sphincter. There's an incidental finding of gastric polyp here. We advise endoscopy for those patients with alarm symptoms. For example, there's a new onset of dyspepsia for patients more than 60 years of age. There's those with evidence of gastrointestinal bleeding like hematemesis, melena, hematophagia, and even occult blood in the stool. Iron deficiency anemia also, anorexia with unexplained weight loss, those with dysphagia as well as odinophagia, and those with persistent vomiting, and history of gastrointestinal cancer in the first degree relative. Now, with regard to the pH monitoring, this is performed either transnasally with a catheter or a wireless capsule-shaped device that is fixed into the distal esophageal mucosa, which conveys data into a computer. And this would confirm the diagnosis of GERD especially for those with persistent symptoms or those who do not respond well to our PPI treatment. Now, esophageal manometry is important in those patients with now impedance analysis is not commonly done. The advantage of this impedance analysis procedure is that it can identify whether the refluxate is acidic or non-acidic. Now, back to our case, on the physical examination, except for the BMI of 33, there were no other remarkable findings. So I would really agree that the patient had typical GERD symptoms, and there's no question about that. However, 1 hour prior to consult, she experienced chest discomfort not relieved by warm water and antacids anymore. So now the question is, are we dealing here with angina pectoris? And this will be answered by our guest cardiologist, Dr. Eugene Reyes. Thank you.
Thank you, Dr. Zanyo, for that nice presentation on the different phases of GERD. Now let me proceed by, of course, explaining the rationale of why chest pain is very important manifestations at the emergency room and the implications and its relationship with GERD. And you know what I'm trying to say is that when you see or face with chest pain, you have to rule out heart disease right away, because heart disease has a graver outcome than people with gastrointestinal manifestations like GERD. Now, many guidelines, we usually classify chest pain as either typical or atypical. And the third classification is what we call non-anginal chest pain. Typical angina should meet 3 characteristics, and they are what nicely described here. A typical angina has constricting discomfort in front of the chest, and it's either. In the past, we only think it should be on the left side, but it's either of the left and right. It should be precipitated by physical exertion and relieved by rest or nitrates within 5 minutes. This chest pain usually lasts only about 10 to 15 minutes, and if you rest right away, it should be gone in 5 minutes. That's the typical of angina. However, if the patient goes to the emergency room, angina or acute coronary syndrome. Now, a typical atypical angina meets only 2 of these characteristics. If you don't have the 3 classical description of typical angina, then you will label this atypical angina. And non-anginal chest pain meets only 1 or none of these characteristics. And for example, if it is only precipitated by exertion and no other classical description like constricting discomfort in this substernal area or relief within 5 minutes, then that's non-anginal chest pain. Now, let me clarify. There are certain characteristic of angina that may be typical, yet if you're not experienced, you might consider it non-angina in nature. One of them is the walk-through angina, which is actually a considered typical angina, and the warm-up angina. Walk-through angina is when a patient started to walk and he experiences angina and he continued to walk, the angina is relieved, and that's what we call walk-through angina. And warm-up angina is when a patient starts to walk and perceive chest pain, then he rests, relieved by rest, and then started to walk again, and the angina doesn't return, and that's what we call warm-up angina. These types of angina are still considered typical angina and should be addressed as part of the syndromical entry disease, coronary calcium score. Now,